Hi, everyone. Good afternoon. Thank you for joining our Neonatal NAS Initiative webinar. My name is Laura Lane, and I am probably the newest member of the GaPQC team. I started last week as the Women's Health Deputy Director at the Department of Public Health. I'm really excited to begin working with all of you all. So I'll begin the webinar with a few housekeeping reminders. Everyone's lines are on mute to reduce the background noise. So please press *6 to unmute. And you can also use the chat box, which I will monitor throughout the webinar. So a quick overview for today's webinar. First, Dr. Patel will share a preview of the updated AAP statement for opioid-exposed newborns. Then Dr. Tama Koala from Emory University will give the main presentation, which is opioids in pregnancy. And Elise Barnes will present an overview of the hospital discharge data. And we do want this to be engaging and participatory, so please chat. And when we open the line for discussion, share your successes and your challenges so we can learn from each other and strengthen our processes. So thank you in advance for your attention and participation. And I'll begin first to highlight a few things about our key driver diagram. So the two Vaughan micro lessons to watch before the next NAS webinar are number 5 and number 8. Okay, and looking at our aim statements, and I know this is kind of hard to see on your screen, the global aim is to improve care for babies and mothers impacted by NAS. So there's no change with this aim. But looking at the SMART aim, which reads, we aim to decrease the length of stay among newborns diagnosed with NAS and participating GaPQC hospitals from 16.3 to 14.7 by September 30th, 2021. So of note here, there is a change in the baseline. The aim now includes all infants diagnosed with NAS. So previously, it had only included infants who were diagnosed with NAS who had not gone to the NICU. So basically, the revised SMART aim includes all infants diagnosed with NAS, whether or not they went to the NICU. So we also went with a 10% decrease from that baseline for our goal, and the baseline year is 2018. So our key driver diagram is updated to reflect that change. So with that, I will turn it over to Dr. Patel. Welcome, and please press *6 to unmute.
Great. Laura, can you hear me okay?
I hear you great. Thank you.
Okay, great. Well, hello, everybody. And I wanted to give you a little bit of an update. And I think first off, we're going to have an upcoming QI learning session call next week on the 19th from 1 p.m. to 2 p.m. So you should have received a calendar invite for that. And what we'd like to talk about and focus on is really about PDSA cycles and testing and some of the pitfalls of it, how you can really use it to really fundamentally make changes that are going to result in improvement, and so we're looking forward to that. But one thing for this call I wanted to do is to get you thinking about some of you may have already done this, but for other centers that are thinking about what kinds of changes we can make, I wanted to share some updates that might get you thinking about changes to make. Next slide. Laura, could you advance it to the next slide?
Sorry, I'm trying.
Yeah.
Okay, got it.
And I wanted to focus on 3 areas that you can consider for testing out changes in terms of what you're already doing and trying to test out before implementation. Those are going to be in terms of monitoring opioid-exposed newborns, about feeding and breastfeeding, and about kind of transitions to home and discharge. And you had a great talk by Claire Eden with the AAP about breastfeeding. But I think these are the 3 areas that I just wanted to briefly touch on today. Next slide. And as we think about this, and this is the key driver diagram that hasn't been updated, but as we think about the primary drivers of how we're going to reduce length of stay and improve care for babies and mothers impacted by NAS, in relation to these three different things I just mentioned, I think they tie in nicely. So if you want to go to the next slide. One is how we can better monitor to identify infants at risk for NAS. Next slide. Next is about improvements in breastfeeding and how we can increase breastfeeding, and I think there's multiple drivers that can address, providing family-centered care and potentially helping with non-pharmacologic treatment. Next slide. And finally, improving transition to home and how we can ensure safe discharges and work on transition to home. And so this is a preview of the American Academy of Pediatrics statement that was just presented yesterday at this large meeting called Hot Topics in Neonatology that is here in Washington, D.C. So you're getting kind of a fresh off the press look at what will likely be coming out at some point next year, which is a statement from the American Academy of Pediatrics Committee on Fetus and Newborn. Wanda Barfield, who's the Assistant Surgeon General from CDC, is the one that has touched on that. And if you want to go back to the prior slide. So in terms of monitoring, these are some of the recommendations in the statement that I think it might be good as you're considering changes to your current policies or potentially updating your policies. Looking at, for chronically exposed infants, the recommendation is they should be observed for at least 72 hours before to monitor for the development of withdrawal. And they then separate out into three groups of infants. Those infants that are exposed to immediate release opioids who should be observed for at least 3 days. For example, mothers who've been chronically using hydrocodone. Number two are infants exposed to buprenorphine or sustained release opioids like oxycodone who should be observed for 4 to 7 days. And the third is infants exposed to methadone who should be observed to 5 to 7 days. So this at least is a glimpse of potentially, depending on, you may be already doing this, but for centers that are considering changes in terms of addressing that first driver of monitoring, these are things that you might want to make sure that at least you're considering based on the pharmacology, the appropriate duration of monitoring for signs of withdrawal. Next slide. So this is on feeding and kind of how we should feed, and one of the goals that the AAP wants each hospital to have, American Academy of Pediatrics, is they should have a protocol for breastfeeding a substance-exposed infant. You saw from our GaPQC, our own baseline data from our first Vendée audit, that our breastfeeding at discharge was around 15%, so I think we have a lot of opportunity to improve. And in these guidelines, there's recommendations for infants of mothers in treatment for opioid use disorder with either buprenorphine or methadone without relapse for greater than or equal to 90 days, that breastfeeding should be supported as long as there's no other contraindications. And then for infants of mothers with active substance abuse or relapses within the last 70 days, breastfeeding should be discouraged. And then for infants of mothers in treatment between 30 and 90 days without relapse, you can consider it. And then just remember, again, HIV is a contraindication of breastfeeding, and hepatitis C is becoming more common among this population of mothers with opioid use disorder, and so just remember about that. I know Claire Eden may have touched on some of this, but just another opportunity as you're thinking about making sure your policies align with allowing the opportunity for mothers to breastfeed, and hopefully we can see that move in the collaborative over the next 2 years, where we're seeing more an increase in breastfeeding at discharge. Next slide. And then finally, they have some guidance on discharge, and one of the points made is that that home pharmacotherapy should be avoided, and it really should be occurring only in limited settings where there's a structured, close outpatient follow-up plan for the diet. And so some systems might be able to provide that, but in typical, this was recommended to be avoided. And then for transitions to home, a discharge checklist, and maybe something that could be considered for testing and implementation at your center is making sure that infants with neonatal opioid withdrawal syndrome have a checklist that you're working on, and these are 6 elements in that checklist that can kind of help you in terms of transitions to home, and a great opportunity to apply checklists as part of care. Some of you may have already done this, and if you're working on it, we'd love to love for you to share some of what you're doing and some of the checklists you're doing. But this is something that I thought, as we're thinking about tackling some of those drivers, just 3 aspects of kind of a brief preview of the AAP statement and some of what they're going to be talking about. And that's all I have. So we'll talk a little bit more about testing and maybe how you can try this out at your center and try to maybe adjust this before you implement it next week. But I want to see if anybody has any questions before we transition on.
Okay. Well, thank you, Dr. Patel. I don't see any questions in the chat box right now, but if anyone thinks of anything later, please just put it in the chat box and we'll email them to Dr. Patel following the webinar.
And we'll make sure to circulate once the statement's formally released. I think it's we'll make sure to send it to all the centers. So thank you all.
Thank you. All right. Next, I would like to introduce our guest speaker. Dr. Sehal Tamakwala is a graduate of New York Institute of Technology College of Osteopathic Medicine. She completed her residency in obstetrics and gynecology at Wayne State University, Detroit Medical Center. During residency, Dr. Tamakwala became interested in opioid use disorder in pregnancy while working under Dr. Carl Christensen and became an ex-waivered buprenorphine prescriber. She joined Emory in August 2018 and is involved in the Maternal Substance Use Work Group at the Georgia Department of Public Health and serves as the GYN OB Department liaison to the Opioid Stewardship Council at Emory. Dr. Tamakwala is currently working on several initiatives to improve opioid safety in the postpartum setting and is on several departmental committees for that. Dr. Tamakwala is also involved in several research projects studying substance use disorders in pregnancy. So welcome, Dr. Tamakwala. Thank you so much for joining us today and sharing your expertise. And I'll turn it over to you and just press *6 to unmute.
Hello, everyone. Can you hear me?
We hear you. Thank you.
Perfect. Hi. Thank you so much for having me. I'm very passionate about this topic, and I'm really glad that I get to share this knowledge with you guys today. So today we're going to look at effects of opioids prior to pregnancy and during pregnancy and the effects that we're trying to avoid here or take care of them over the next, in the neonatal period. So this is looking at the pregnancy portion of it all, of how we can help with the situation that we're in right now. Next slide. So I don't have any financial disclosures. Next slide. All right. So the objectives of this talk, I don't know why my headers are not coming up, but I'll just tell you guys what they are. Yeah. All right. Yep. So the objectives of this talk, number one, is that how do you diagnose somebody with opioid use disorder in pregnancy? What is medication-assisted treatment? And what are some of the things you could do in prenatal, intrapartum, and postpartum period for from the maternal standpoint? And some of the things that you guys already actually mentioned about breastfeeding and infant care in the postpartum period. Next slide. Okay, so of course, this looks like an image, but I'm sorry, I don't know why that's happening. But opioid use disorder in pregnancy, there are several different strategies that have been proposed to help us address the situation. Where there's an SBIRT strategy that has been proposed, where we would do universal screening for all women who are pregnant, And depending on what the screening results are, a brief intervention at the time of the appointment itself, and refer the patient for appropriate treatment would be the next step. So SBIRT strategy is the most commonly used strategy to help identify patients who may have opioid use disorder and then transition them into proper appropriate channels for care during pregnancy. Next slide. So universal screening. So screening for substance abuse should be a standard practice at every woman's first prenatal visit, regardless of ethnicity or socioeconomic status. And that's something that ACOG has, ACOG, which is American College of Obstetrics and Gynecology, they have really highly recommended that we check every single woman for substance abuse. And there are several validated screening tools that are out there, and I'll go over a few of them in the next couple of slides. But the only thing about the validated screening tools is that it does definitely rely highly on patients being honest, and also patients who are actually coming in for prenatal care. Some patients don't even show up for prenatal care. So there are definitely some limitations to using that, but it's definitely one step that we can take to help address the situation. Next slide. So some of the most common screening tools that are used in the field of OBGYN, they are the NIDA, or National Institute of Drug Abuse Quick Screen, and CRAP Screen, and 4+ screen. So these are some of the ones that have been used to not just look at opioid use disorder, but look at other substance use disorders as well during pregnancy. Next slide. So the 4 Ps is something that we tend to use more often, and it is for pregnant patients, where you look at the 4 Ps in the patient, where parents, like, did any of your parents have a problem with alcohol or other drug use? Partner, do you have a partner with similar issues? In the past, has the patient itself has had any issues with alcohol, drugs, or other prescription medications, and what the present status is for the patient. And if the patient says yes for any of the questions, then it would trigger further questions depending on what they answer. Next slide. The CRAFT one is usually used for adolescents and young adults. We do get quite a few adolescent patients who are pregnant, and this has been shown to be more effective in that patient population, where you look at the C is about have they ever ridden in a car by someone who has been high or have been abusing alcohol or drugs. R is, do you use alcohol or drugs to relax or feel better or to fit in? And do you ever use alcohol or drugs while you're by yourself or alone? And do you ever forget that you things that you did while using alcohol or drugs? Like, are you having any blackouts? The other F stands for family. Have they had any family members who have told them if they need to cut down on their drinking or drug use? And the T stands for trouble, where have they ever gotten into trouble while using alcohol or drugs? And if they have any 2 of those points, if they're positive, then that requires further assessment and brief intervention in these patients as well. Next slide. So now, switching gears, we want to talk more about risk factors. Why are some patients more prone to having issues with substance use disorders and some not? So the risk factors have been categorized into 3 major groups. One is genetic, and it's responsible for 40 to 60% of addiction. And that's something to really keep in mind, that if you have a patient who has a family history of substance use, that they are at a significantly higher risk of developing something similar at any point in their life. And then looking at environmental factors, definitely patients with low socioeconomic status and poor parental support, and if they're in a wrong group, they're more likely to be exposed to substances at an earlier age, and in turn be using substances at any point in time of their life. And then all the other environmental factors, they go along with the low socioeconomic status in a certain way, with like low level of education, they're unemployed. So it's interesting that Caucasian population was found to be more at risk of developing substance use disorders. And last but not least, very important of all of them is mental illness. That it's very important to know that 30% of people who have psychiatric diagnoses, they abuse drugs. So that's something to also keep in mind. And you want to think about all drugs like alcohol, nicotine, and other drugs included in this in the substance use disorders. Next slide. So some of the adverse effects, like why do we care so much about this? Why do we care about opioid use disorder in pregnancy? And some of the biggest reasons are intrauterine growth restriction, placental abnormalities that could in turn lead to intrauterine growth restriction, premature delivery that once again goes along with that, and preterm, premature rupture of membranes, postpartum hemorrhage, and perinatal, maternal or fetal death. Or neonatal death, and of course neonatal opioid withdrawal syndrome. Next slide. So opioid use disorder, how do you diagnose somebody? So opioid use disorder is a problematic pattern of opioid use which leads to clinically significant impairment or distress in a patient. And DSM-5 came out with these 11 criteria that are in 4 separate categories to determine if a patient has opioid use disorder. And just breaking them off in 4 different big categories. Impaired control. Do they have a craving, strong urge, they have tried to cut down but they can't cut down, that's impaired control. Then looking at the social problems that the patient's having, like do they have issues with their work or school, or are they giving up on their leisurely activities or just so that they can abuse substances. And looking at risky use, using drugs, knowing that they may contract HIV if they're using used syringes, or trying to obtain drugs from a risky setting from a drug dealer where they can easily get killed. So things like that. So that's risky use. And pharmacologic effects. Does the patient have any evidence of tolerance or withdrawal symptoms, especially in an event where they stop using drugs? Do they have any effects from stopping? And depending on how many answers they have, if they meet certain criteria, they may be in mild, moderate, or severe category. Next slide. So there is the CPOD versus OUD. CPOD is something called complex persistent opioid dependence versus opioid use disorder. And there's a very big difference between the two. And the biggest difference is that dependence is complicated by desire to continue taking opioid for the treatment of pain. And that withdrawal is complicated by anhedonia or having more pain, which are unlike some classic physical symptoms of withdrawal. So patients continue to take pain medications because they don't want to feel pain, and not necessarily because they would withdraw from the medication. So that's something very different. And so the difference between the two is that with CPOD, which is complex persistent opioid dependence, you don't have any cravings, you don't have a compulsive use, there is no harmful use that is not medically directed, and they don't have any social disturbances. So that's very important to distinguish, especially now, with patients with chronic pain. They don't tend to get their pain medications appropriately because physicians and other providers are afraid of prescribing opioids, even in pregnancy. So just to be fair, or just to be better providers for our patients, it's very important to be able to see the difference between the two, that OUD is something that's more dysfunctional and that it does cause significant impairment in their lives, versus CPOD. They're just using the opioid just so that they don't feel the pain and that they don't have a problematic use with the medication. Next slide. So women with opioid use disorders, they are at risk for polysubstance abuse, and that's something to always keep in mind. And that and that also they are at risk of engaging in high-risk behaviors such as violence, incarceration, or exposure to sexually transmitted infections. Next slide. So once the next steps after diagnosis, that's the title of this slide, what are some of the things that you could do once you diagnose somebody with opioid use disorder? You want to, number one, try to screen them for infectious complications at prenatal care and in the third trimester if the risky behavior continues throughout pregnancy. So the first several labs that we do, HIV, hepatitis B, gonorrhea, chlamydia, and syphilis, they're common for all pregnancy patients. But for patients who have opioid use disorder, we add hepatitis C and tuberculosis for those patients. Especially the ones that have history of incarceration or homelessness, because they have higher incidence of having tuberculosis. And once you do have the patient in your care at the first prenatal care visit, of course, you want to do a thorough history and physical examination. You want to evaluate them for cellulitis, make sure that they're up to date on their tetanus, if they have any exposure to anthrax, anything like that that is more likely in patients who are IV drug users. And look at nasal septum if they're snorting their opiates, and evaluate the patients for mental health disorders. And here you would see that patients, 65% of patients who have substance use disorder have a mental health issue. And that's slightly different from what I said earlier, that patients with mental health disorders, they are at increased risk of having substance use disorder. That percentage is slightly lower, which is 30%, versus here, where 65% of patients with substance use disorders have mental health disorders. And also very important is screening these patients for physical and sexual abuse, especially because they are at risk for these issues. 72% of our patients who have opioid use disorder are at risk of having some sort of physical abuse, 71% have emotional abuse, and 44% sexual abuse. And sexual abuse continues to stay high in pregnancy, abuse rates continue to stay higher during pregnancy, especially emotional abuse and physical abuse. Next slide. So what are some of the barriers to care? Why do some patients don't come in and get care, or cannot get into a treatment facility? Number one reason is limited financial resources. They don't have enough money, they don't have transportation to get to appointments, and the biggest thing is that if a patient is getting medication-assisted therapy for opioid use disorder once they're diagnosed, they have prenatal care appointments to follow up as well. So having two separate visits, it's a huge strain on their life, and that's something that we need to address, especially in the state of Georgia, where I'm practicing in Atlanta. That this service is thoroughly lacking in this region. And also lack of social support. If they have additional children, they don't have care providers who are going to take care of their children while they're at these appointments. Social stigma of actually finding out that you have opioid use disorder and accepting that. Or also fear of litigation. At least Georgia is better about that, but some of our neighboring states are not that nice to pregnant women who have issues with substance abuse, and that's something to keep in mind as well, and to reassure our patients during care that they won't have to deal with that, especially in the state of Georgia. Also, low levels of self-esteem and education, and of course, non-compliance to treatment. Next slide. So if a patient is positive for OUD or opioid use disorder, now what do we do? So the next step is brief intervention. And in that scenario, you try to ask further questions to get to the bottom of the situation. And then once you have engaged the patient in a non-judgmental conversation, you can provide them feedback, advice, and then biggest thing is referring the patient to appropriate treatment services. The slide is it's not coming up properly, but the last point is referring the patient to appropriate treatment service. Next slide. Okay, so if the patient meets criteria for opioid use disorder, Number one, you want to explain to the patient and people who are taking care of the patient that opioid use disorder or any substance use disorder is a chronic disease and it's not a moral failing as was once thought several in the past. And you want to explain to the patient and everybody else involved is that there are some permanent alterations in your brain chemistry when somebody is exposed to substances for a long period of time, and that once a patient gets into recovery, they're always in recovery. It's like diabetes. It's a chronic condition that you have to keep up with. And also never, ever, ever, ever call a patient an addict or a junkie. That just does not help take care of the patients. Next slide. So some of the treatment strategies are, there are two trains of thought. One is the opioid detoxification, where you do systematic withdrawal withdrawal in pregnancy, and the other is medication-assisted treatment. And with medication-assisted treatment, there are two major medications that are used, such as buprenorphine and methadone. Those are the two big ones that we use. And there is certain, in the most recent studies, there have been some talks about possibly considering opioid detoxification in special populations, in certain patients only, who are at a lower risk of relapse, and that somebody who is not using high amount of opioids, that's something that could be considered. But currently, medication-assisted treatment is the best thing we can do for our patients in pregnancy. So next one. So right here, as I said, it's not recommended for pregnant women because of high rates of maternal relapse and potential fetal risks associated with intoxication or withdrawal, and that's why it should be used only in a select number of patients who don't have those risk factors, because going through cycle of intoxication and withdrawal is what leads to preterm delivery and other neonatal effects. So that's something that should be done very carefully. And patients should be under supervision of a clinician when they are going through withdrawal. It cannot be withdrawing at home or something like that. A lot of the times patients need to be admitted to an inpatient setting to help them withdraw in a more controlled fashion. And you want to continue following those patients who have finished opioid detoxification to continue to make sure that they are staying sober, and provide them plenty of support. Very important to plug them in with psychiatry to help assess their situation on a constant basis. And if you were to do opioid detoxification, second trimester is the right time to do it. Other than that, methadone and buprenorphine are the mainstay of treatment at this time. So I want to talk a little bit more about methadone and buprenorphine in the next several slides. So why use medication-assisted treatment? Because the patients are more likely, the neonates are more likely to be discharged to the care of their mother and remain in care of their mother at 1 year of age if they use a medication-assisted treatment. And it also decreases risk of preterm delivery and placental abruption and intrauterine fetal demise. And that's very important from a neonatal standpoint. And delivery of low birth weight infants and NICU admissions are also lower with patients who are on MAT versus who continue to abuse opioids during pregnancy. All right. So very important, as I said, psychotherapy is very important to plug the patients in with psychiatry at the time of diagnosis for concurrent treatment, because that has been shown to improve patient outcomes and to ensure that they continue with their therapy and their treatment throughout the entire pregnancy and beyond. And some of the things that have been utilized by psychiatry are cognitive behavioral therapy and contingency management, especially for these patients. And also addiction psychiatry, like enrollment in addiction counseling, if possible, would be the best thing to do for these patients for higher retention. Next slide. So methadone. So methadone is a long-acting opioid agonist. So it works the same way as any opioid the patient would use, like heroin, but it's a longer-acting medication, so they don't need to inject multiple times, and it's a medication. So it's the risk of obtaining the drug and possibly getting infected with other HIV or hepatitis C is lower if a patient is enrolled in a program where they can get their medication appropriately. And methadone at this time is only prescribed through federally licensed and regulated clinics, and that a lot of the times patients do have to go every single day to get their medication, and only special patient population who have demonstrated that they are trustworthy, they get to take home some pills over the weekend. But methadone clinics are not evenly distributed throughout the states, and sometimes that can restrict use and availability of the drug in the treatment of addiction. And just a few things. It's not very not important for this group in general, but there's some medications that are used for HIV that can interact with methadone, and that it's very important to keep that in mind for patients who have HIV and who are opioid use disorder who are started on methadone, that they may need to have increase dosages of methadone to prevent withdrawal. Next slide. So this is about buprenorphine. Buprenorphine is a partial agonist of the mu-opioid receptor. So, and it competes with heroin or any other opioid at the receptor. So if buprenorphine is present in the bloodstream, it's less likely for the other drug or heroin to actually dislodge the buprenorphine from the receptor, and that it's highly effective. And there are several different formulations out there, but in pregnancy, sublingual administration is what's preferred for opioid use disorder. And some of the other things is that it works the plasma concentration increases within 40 minutes to 3.5 hours after administration. It's highly lipid soluble, and that its primary metabolite is norbuprenorphine, which is what is actually working. And sometimes drug-drug interactions, once again, do exist with some of the HIV medications and some antifungals, and that's just to keep that in mind when we're prescribing, that we may have to increase the dosage for those patients. And that we want to discuss or tell the patient that methadone currently is standard of care during pregnancy, and that buprenorphine is not FDA approved for use during pregnancy. But several different studies have shown that buprenorphine actually may be slightly better than methadone in pregnancy. We can move on to the next slide. So buprenorphine, once again, as I said, it's a partial mu agonist, and the great thing about this medication is that it has a ceiling effect. So after a certain dose, if you look at all the other opioids out here, fentanyl, hydromorphine, morphone, or morphine, if you continue to increase the dose, you're going to have continued increase in effect. But with buprenorphine, you will see that after a certain increase in dose, the patients are not going to feel that high. They're not going to feel that. And buprenorphine is mainly to help curb the cravings the patients would have. And that it's useful also for some treatment-resistant depression, as a side note. Next slide. Yep. So buprenorphine, there are many different formulations, as I said. You can actually continue to just load the other two, yes. So the two formulations that are primarily used in pregnancy are Subutex, which is a sublingual buprenorphine, and then Suboxone. So the difference between the two is that Suboxone has a component called naloxone within it, where certain patients can actually boil their sublingual tablet down and then inject the medication. inject buprenorphine into their bloodstream, and that has a better effect than taking it sublingually. So naloxone helps prevent that behavior because the patient's going to start withdrawing immediately if they inject that formulation into their bloodstream. So once again, Subutex is also a privilege. Not a lot of patients end up getting that, but if they have demonstrated that they're trustworthy, then they do get Subutex. Next slide. Okay, so methadone versus buprenorphine. How do you decide? It's individual choice. You have to figure out the patient population. And that while methadone does continue to be standard of care at this time, there is significant amount of research in the last 10 years that has shown that buprenorphine is a safer alternative, and that there is decreased incidence of neonatal or opioid withdrawal syndrome in neonates, and there's less likely to be respiratory distress at delivery in the neonates. Also, there have been shown to have fewer maternal complications with buprenorphine, such as preterm labor and overdoses, and also shorter duration of infant hospitalization. And the shorter duration is only by a few days, but that also that adds up in the whole scheme of things with cost of healthcare. And buprenorphine-exposed fetuses have also strong indications of fetal well-being, including heart rate variability and accelerations. Those are some of the components that we look at in labor to ensure neonatal and fetal well-being in utero. And also, once again, similar thing, less suppression of fetal heart rate and biophysical profile score after medication dosing with buprenorphine. So those are some of the things that are really great about buprenorphine. And some of the long-term data about potential effects of buprenorphine on the fetus, they're limited, and that we still need to talk to the patients that it's not currently FDA approved for treatment of OUD in pregnancy. Okay, next slide. So who can prescribe buprenorphine? I can actually load those. Yep. So everybody, you can in theory, because anybody can get a free, you can get your free training and a waiver, DEA waiver to prescribe buprenorphine. So that's something to think about, that if you have a high patient population that would be a good candidate for that you could possibly be an asset in the community by providing that care for pregnant patients. And of course, there are many different providers that are out there. You can actually search them on SAMHSA website, where you can find who provides or who prescribes buprenorphine in your area. Addiction psychiatrists with fellowship training can prescribe buprenorphine, and other addiction medicine providers that have been grandfathered into the field who did not necessarily finish fellowship training as well. Next slide. So prenatal care for patients on medication-assisted treatment, it's definitely a multidisciplinary approach. You want to get as many people involved as possible to have the greatest success for these patients. So of course, obstetrics, pediatrics, and mainly neonatal, neonatology care, addiction medicine, and social services involvement is very important throughout pregnancy. Frequent visits and growth ultrasound every 4 weeks to make sure that we are assessing for intrauterine growth restriction, and in turn, which is a risk factor for intrauterine fetal demise. Doing NSTs, which is non-stress tests, or biophysical profiles. These are just surveillance tools that OBGYNs use to assess fetal well-being. And if the patient is smoking, you want to address smoking cessation. 80 to 95% of those patients are smoking cigarettes. So that's something to keep in mind. And you always avoid benzodiazepines in patients with concurrent anxiety, with patients who are on medication-assisted treatment, and that you want to try alternatives because of increased risk of respiratory depression. And assess for social factors. If they're homeless, help them with that. Assess their nutritional status, any other psychiatric conditions they may have. We're going to address all of that during prenatal care. Discuss contraception and urine drug screening at every visit while on medication-assisted treatment to ensure that patients are being compliant. Next slide. So ACOG, which is American College of OBGYN, and ASAM, American Society of Addiction Medicine, they both recommend that while it's not standard of care for screening for substance use during pregnancy, it's very important that we start, we at least screen the patients with those little tools that I told you about prior to doing urine drug screening. So you also want to obtain patient's consent prior to doing a screening urine drug screen because in certain states it requires OBGYN providers to actually notify the state of a positive drug screen, and that those drug screens can actually be used for litigation purposes and could be detrimental to our patients. So that's something to keep in mind. Once again, we're lucky here in Georgia that we don't have to report, but in certain states, that's something to keep in mind. And of course, if you have a patient who had an unexpected positive, then you want to do a confirmatory test. Next. So that very important, know your state laws. That when you are thinking about doing certain things, especially in the pregnant population, as I said, some states are not very nice. Georgia is, so we're good. I added this link here just to look at different states if you are unsure about a particular location. Next slide. So in terms of preparing for delivery, you want to reinforce doctor-based confidentiality. If the patient's family is visiting and they're unaware of patient's medical conditions, you want to make sure that you maintain that confidentiality throughout labor delivery process. Pain management during labor, a lot of these patients can have issues with experiencing more pain than usual, and that's something that can be managed with the help of anesthesia. And discuss neonatal opioid withdrawal syndrome with the patient prior to delivery. Address if the patient's partner is involved in care, and it's gonna help raise the child, just to assess if the patient, if he or she is also needs substance abuse treatment. And of course, you want to assess home safety prior to discharging the infant. Next slide. So now you have a patient who is on labor and delivery. If they are on buprenorphine or methadone in labor, you do not want to discontinue them. You want to continue their medications because it may lead to more withdrawal and other complications related to that. So first and foremost, you want to continue your medications. And for buprenorphine, since it's a partial mu agonist, there have been instances where patients may require higher and higher dosages of narcotics to actually help with pain. And so one of the things that has been proposed is using split dosing for buprenorphine, where you split the dosage to minimize the amount of opioid receptors being taken by buprenorphine. And epidural analgesia is preferred for all the patients if they are candidates who are on buprenorphine or methadone to help prevent or avoid giving them too many narcotics during labor. And if IV administration is needed, just remember that you may need to give more than necessary. And there are certain partial antagonists that we use for pain control during labor, and those are some of the things that we cannot use for this patient population because they will withdraw immediately. Next. So during cesarean delivery, once again, you don't want to discontinue buprenorphine or methadone. You continue them, and then epidural or spinal is recommended, and that you may use your usual intraoperative pain protocols for these patients along with their medication-assisted treatment. And also you want to, because a lot of the times the patients are awake during cesarean deliveries and then they may feel pressure. A lot of the times these patients may need more coaching to realize or to understand that normal pressure pain is common in C-sections and that it's not true pain that needs to be addressed. Next. For postpartum purposes, regardless of mode of delivery, once again, you want to continue buprenorphine and methadone. And for vaginal delivery, usually you can use your NSAIDs and acetaminophen, ice-packs. You want to use other modalities to help with pain besides opioids. And if the pain is severe enough, then you can consider using opioids. But that's something that should be reserved for really severe pain after a vaginal delivery. And then for C-sections, once again, you can continue the epidural after 24 hours into the 24-hour postpartum period to help minimize usage of opioids. And then once again, you want to use other modalities prior to starting narcotics or opioid medications. Next slide. Breastfeeding, we did talk about it. But actually, in terms of medication-assisted treatment, I wanted to go over that buprenorphine package insert does advise against breastfeeding. But ACOG and ASAM, once again, they have said that patient stabilization with opioid-assisted therapy, including buprenorphine, is compatible with breastfeeding. So once again, you want to tell the patients this information exactly the way I just told you, to let them know that the package insert says A, but our societies who actually take care of these patients, they think that it's okay to take it. And in methadone, you can continue taking it. Next slide. Careful evaluation of benefits and risks of breastfeeding with opioid use disorders. Once again, this is what a prior speaker just mentioned that. I'm not going to go over it. It's the same exact slide. And that breastfeeding is recommended for women who have been abstinent from illicit drugs for 90 days prior to delivery in an outpatient setting, and that they have received consistent prenatal care, and that it's not recommended for the other two. And then case by case is patients who have achieved sobriety within the last 30 days prior to delivery. Okay, next slide. So breastfeeding, the relative ingestion per kilogram of infant body weight is less than 1% of the dose per body weight of the mother for buprenorphine. So breastfed infants, once again, have less severe neonatal opioid withdrawal. Hep C is not a contraindication unless nipples are cracked or bleeding, and HIV is a contraindication in the United States. But abroad, in low-income countries, it is actually, HIV is still not a contraindication. Discharge planning, refer the patients to an addiction specialist after delivery. Whoever has been maintaining or managing patients on medication-assisted treatment, you want to send them back, and contact the patient's prenatal buprenorphine prescriber if there's anything else that needs to be done prior to discharge, and continue them on their same dosages that they came on before. And if you do anticipate that there is going to be some delay in care, with reestablishing care with their buprenorphine provider, a provider with a DEA waiver, either on the hospital team or on the outpatient team, must write a prescription for enough buprenorphine to last until the next follow-up appointment. So that's something to keep in mind. And close follow-up, very important. And after delivery, there is an increased risk of relapse if the patient stops MAT. Postpartum period already puts a lot of stress on a woman, and having issues with opioid use disorder can actually make that worse. So there is increased risk of relapse, and you want to follow those patients closely in the postpartum period. Next slide. The next few slides, I'm not going to go too much over them. They're actually, there is new data that just came out, but this is more about surgical care, and that is not necessarily like for more of GYN surgeries and things like that. It's just going over some of the protocols where if you whether to stop buprenorphine or not. And some of these things are actually already outdated. But I decided to keep it in the slides just in case you do end up having a patient going through surgery that may be on buprenorphine. Next slide. Yep. And then, so this is just a clinical opioid withdrawal scale that we use in the hospital for all the patients, even pregnant patients. So next slide. So in summary, opioid use disorder is a chronic disease and it's not a moral failing, and that's something to really, really understand that, and that most post-detox patients will relapse without treatment, greater than 90%. So opioid detoxification on its own may not be the right answer for most of our patients, and that only a select few could be candidates for that because there is a significantly higher rate of relapse. And treatment for opioid use disorder, it works, and we need to get our patients into these treatment programs. Any questions?
Thank you so much, Dr. Tamakawala. If anyone has questions for her, please press *6 to unmute, or you can put it in the chat box. Okay. Well, again, thank you so much. We appreciate you joining us this afternoon. We'll move on quickly to Elise Barnes. She is our epidemiologist here at DPH, and she's going to present the hospital discharge data. Elise, *6 to unmute.
Hi, everyone. Can you hear me?
Yep.
Perfect. That was a wonderful presentation, very informative. I am going to run through the hospital discharge data very quickly. I know that some of the facilities during the Bondi audit did not have infants that were eligible for inclusion, or they just didn't have enough infants to get a very good baseline for their length of stay. And so I have gone through the hospital discharge data and calculated length of stay for the state, and then also I've created some individual facility-specific reports that Katie or Laura will be sharing with you all. You can go to the first slide. This is an example of what you will receive. I know it looks kind of busy, but basically what I have done is pulled data from 2017 through 2019. 2019 hospital discharge data is preliminary, so you will see that it only goes up to Q2. We will be awaiting Q3. Hopefully we'll receive that at some point soon, but I would take all of the 2019 information with a grain of salt because the numbers seem very low compared to previous years. So hopefully that will change as it goes on. I have split it into the quarters, and then you'll also see that it was split into exposed and primary cases. When I say primary case, I mean that they were coded at discharge with the ICD code P96.1, which is infants experiencing withdrawal. And then when I say exposed, I mean those P04.9 ICD code, which is maternal use of other drugs of addiction.
Can we go back to that slide, please?
Yes, that would be great. One of the things that I would like to note is that starting October 1st, 2018, which is Q4 of 2018, the ICD codes were updated. This happens, there's an annual update every year with the Centers for Medicaid and Medicare Services. And so additional exposure codes were added. And so starting Q4 of 2018, the exposed category also includes some P04.1 codes. It includes newborn affected by maternal use of opiates, sedatives and hypnotics, and anxiolytics as well. So I provided this for each of the facilities that are participating in the VAUGHN initiative. Some of the facilities you'll find do not have very many cases, exposed or primary, and so you may find a lot of cells that look like the 2019, where we can't get a confidence interval. You may not have enough cases to even get a good mean. So that's something that you'll just need to check once you receive your own data. And if anybody has questions about how to interpret it, you can always contact one of us. There is the overall column at the end, and that's kind of what you might be best to look at. The broken up by quarter can be a lot to take in. You can go to the next slide. I just wanted to provide this really quickly to show where we got our initial baseline measure that we were quoting. This is from the 2017 NAS surveillance report. We were using the 11.2 days as the average length of stay baseline measure, but the way that was calculated was only including nursery infants, so that excluded NICU infants. Obviously, the Vaughan Initiative kind of focuses on NICU, and so this is not shown to be the best measure. If you want to continue. So this is a chart for all of Georgia, and it's split once again into exposed and primary cases. This is by 2017, 2018, and then the first 2 quarters of 2019, which, like I said, is preliminary. When we redid the average length of stay for all of Georgia, we calculated at 16.7 days, and that is a potential baseline measure that we're going to use. We have not received the data yet to split into NICU and non-NICU infants, and so the number like the chart in the 2017 surveillance report is not available at this time. And you can move on to the next slide. This is the measure that I think has been updated in the SMART aims. This was calculated for just GaPQC facility participants. So we have got about 16.3 as the average length of stay for 2018 for cases that are coded as experiencing withdrawal. And that is the number that we have been told that we're going to use for now. So that's all I have for y'all. If you have any questions, I know that this went by pretty quickly, but like I said, if you need help interpreting any of your own data once you receive it, feel free to contact us and we would be happy to give more of an explanation.
You know, it's interesting, the interval's pretty tight on that.
Yeah.
If anyone has questions for Elise, just *6 to unmute. Comments or anything anyone would like to share with the group? All right. Well, thank you so much, Elise, Dr. Tamakawala, and of course, Dr. Patel. We appreciate you all sharing this with us this afternoon. Quick reminders are on the screen. Let's see, the December 19th is the QI Technical Assistance Call with Dr. Patel. Tuesday, January 2nd is the next Neonatal NAS Initiative Collaborative Call, and that is Eat, Sleep, Console. And I just want to thank you all again for your participation today. And in the collaborative, if you need anything, feel free to reach out to me, Laura Lane, or Katie Kopp here at DPH. Thank you so much, everyone, and enjoy the holidays.